If you decide to go for the management, then you must provide the education to the patient, counsel the patient, and then give the specific treatment as per the list O, because this is the first consultation of the patient. In case the consultation is on a video, then you can prescribe medicines from list A. In the follow-up, again, similar process is followed. So first assess if there is emergency. If yes, ask patient to go to the hospital. If no, assess the patient. If you can manage on teleconsultation, proceed. Otherwise, ask the patient to come for a physical consultation. And this is the flow for the health workers when they consult you. Again, the similar flow is there. I'll not repeat this. And there is a template for prescription. So all the prescriptions that you provide to a patient while teleconsultation, they must have identification of the doctor, his qualifications, his registration number, patient's vitals, patient's details, complaints, and medicines in details as per this format. There are some do's and don'ts. So if you are using an app for teleconsultation, be familiar with the app. Do not use some app for the first time. Don't try it. When you are doing a video consultation, better to have adequate light in the room. There should be dark background. It should be a quiet room. Avoid doing in the dark, and wear some dress appropriately. At least wear clothes, because sometimes doctors even consult from their bathroom, so that should be avoided. Dress appropriately. Don't wear the loud clothes. And introduce yourself if you are doing for the first time. Ask the patient for ID if you are not sure the patient is the same patient. Don't prescribe any drugs that can harm the patient. Avoid the drugs from the Schedule X or the drugs which are prohibited. If you require a physical examination, ask the patient to come for personal consultation, and don't do it on the teleconsultation. For the first consultation, you should prefer a video consultation. Don't do it by audio. Take the consent and preserve the documents if the patient, if you are initiating consultation, or if the patient is not consulting for himself, if somebody else is consulting for the patient. Inform the patient that you are available for teleconsultations, but don't solicit the consultations. And this is what we all do. So when Manoj said that I don't do teleconsultations, I am sure everybody has done this. So telephone calls I can put here, but screenshots I can put. Patients will ask you on WhatsApp, they will share some complaints, they will ask on even Twitter or emails. And then we usually reply back to them with some advice. That must be avoided, because as per definition, this qualifies to be teleconsultation. If something wrong goes to the patient with the patient, then you are at fault. So my advice at the end is to go more for telemedicines, but do it appropriately. Don't do it by text messages or those. Either use some professional app, but then there are limitations. So these are the telemedicine apps. I'll just quickly run through them. But the limitation is that if you use these apps, don't expect that you will get new patients from these apps. Mostly these are the patients of yours, and you ask them to go on the app. And once you go on the app, or the patient goes on the app, then the patient will be sold labs, he will be sold medicines, he might be going to some other doctor also through this app. So that's a risk that you are taking when you recommend a patient any particular app. The other alternative is that if you are using some EMR, like this one is the one that I use, they also have a module for online consultations, and that can also be used. And if you are not sure of that also, then maybe you can do through WhatsApp calls, but I prefer not to have that phone with me. So the phone is with the receptionist. The receptionist initiates the call, patient makes the payment first, then he consults me, and then you must document that consultation on EMR. If you do that, then you are taking care of the requirements that are necessary for the guidelines to follow. So this is how you can do the consultation. So I'll end my presentation here. Thank you very much.
Thank you for a very elaborate presentation. Thank you very much. It was a lucid presentation. So we come to the end of today's this aspect of the morning session. Now it's time for a little break and something which we all are looking for the lucky draw.
He wanted to ask one question. You are allowed now, please. No, you said. Acha.
A lucky draw will be unveiled now, sponsored by YChem Laboratories. I would like to call upon stage Director of YChem Laboratories, Mr. Subroto. I would also like to invite Dr. Rajiv Chawla on stage to do the needful.
Just correction, I am not director, I am a sales head of this company.
There's a correction. Mr. Subroto is Sales Head Officer of YChem Laboratories.
Good morning. A disclaimer, I am just doing it as a courtesy, so I may be lucky for Manoj and unlucky for maybe Amit, so don't later blame me. So this should be the first prize or third, second, first? This first prize? Okay. So this goes to Puranje, not very clearly written, Chakravarti or something. He had it? Just check it again. So this guy is too lucky getting it for the second time. So I'm looking for a slip which matches with Manoj. Now this is first prize. Dr. Arjun Badya. So first prize goes to Dr. Arjun Badya. He is not here, but you will, yeah, please keep it. You may mark it itself. Second prize goes to Dr. Ayan Mondal. AYON, Dr. Ayan Mondal. You may mark it and you will have to reach to them. And third prize goes to Dr. Abhijit Sarkar. Manoj, I am sorry. I think most of the delegates are from Kolkata only, and they are the one who have filled it. I think you didn't provide opportunity to faculties. नहीं ऐसे नहीं सारा ऐसे किया मैंने, सारा चेक किया मैंने. Well, this is Dr. Vasant Kumar. Sir, you have to come here. So I think now this draw is justified. Vasant sir, please come. So now you need a person to carry it. I'll help you out. Good.
Thank you, sir. Now we move to the respective halls and we start the next sessions.
Thank you for the nice introduction, and thank you to the organizing team and being as one of the founding members of
everyone,
DRWA.
Please take the seat. Please take
Happy to be again with our glorious annual meets of DRWA. Today I have given the talk, I was given a chance to talk about HbA1c, what we commonly do day in and day out for glycemic control in the diabetic patients. So it is apparently a very simple test, and it has been endorsed by ADA and all the bodies throughout the world. But what are the things which we should be careful when we interpret the HbA1c for the glycemic control, though we commonly miss the situation sometime and misinterpret the HbA1c if the underlying disease or drugs or other pathogenesis is there. For that, we need to read the graph carefully, and where I am going to talk about. So HbA1c is a central role for management of diabetes. It derives from the use of report of the major outcome studies throughout the different big trials. So it starts with the 1962, which did show that increased HbA1c fraction in the RBC, HbA1 fraction in the RBC for diabetic patients. From there is a gradual awareness and increasing detection of HbA1c related metabolic control in 1975. DCCT, UKPDS used that in 1993 and 98, and 2010 ADA recommends the diagnosis of diabetes and prediabetes for HbA1c. This is how the glycosylation and amyloid products are made, and it looks like. So this is adult glycated and non-glycated hemoglobin. So this is hemoglobin, adult A, A2, and hemoglobin F, which is fetal hemoglobin in most of the time, unless there are some hemoglobinopathies. So this is the non-glycated hemoglobin A0, and A1 is the glycated one, and for which A1B is a 1A and 1B is a very low concentration. Mainly, which we are concerned with is 1C, which is around 5%. There are different methods of HbA1c assessment, charge-based to structure-based, because each of the methods has their own advantages and pitfalls, like ion exchange chromatography. These are the best one, HPLC, isoelectric focusing, from the structured-based to weak acid hydrolysis, Burnett affinity chromatography, and immunoassays as well. So, post-1993, the IFCC reference standard gradually came in. So based on the assaying a specific component of hemoglobin A, that is beta N-terminal hexapeptide, it expressed in millimole per mole in unglycated hemoglobin. This is how it is calculated. We have given the formula. So, and this is the estimated average glucose we measured from the HbA1c. This is again very standardized by the ADA. This is adapted from the ADAC studies, and how we measure the average glucose, and it is pretty accurate unless there is underlying disease. So, and this is how the graphs are read. What I'm saying is that first we look at the base. This is the base. When we commonly look at the HbA1c value only when we get the printout of the reports, but in the next page you find this graph. If this graph has equal importance, for example, first is this base. This base should be straight line. It is very irregular. Then again there is an assay effect, and the area count should be 1 to 5 million. This from here to here you can see it is 2.8 something like that. So it is less than 5 million. If the area count is below and above this, it should be diluent with the diluents and processed again. So it is erratic again. So if you find that value is more than 5,000 or less than 1,000, you discard the graph and don't accept the result. Similarly, there is a P3 peak. We can see here, this P3 peak, if this is more than 8%, it means a sample is clotted and it is not stored properly, and it has to be a fresh samples testing. So again, when you read the prints of the graph interpretation, you read that carefully. That is important. If the reports are altered, as I said, even if the graph shows HbA1c is 6, you do not accept that. Next is that thing which should be checked, retention time of HbA1c and HbA0, as in the graph 1, HbA0 and A1c, these detention times are very important. And HbF, what you commonly see is very low, as we have discussed, and the fetal hemoglobin component, it should be less than 10%, and there are ratios of H1C and HB. These are the different ratios. Again, these ratios are calculated here, and these ratios should be less than 4% and less than 3.5% respectively. And this whole system of the graphs, which we commonly use for the interpretation, can detect the HbA1c from 3.8 to 18.5. It's quite a big range, but if it is very high, you cannot interpret with this graph. Again, there is an estimation limit. So that again should be kept in mind. If the blood sugars are very high for certain times, HbA1c more than 18, if it is there, it's erroneously reported. Again, these are the different components of normal chromatogram to HbX, the position of the different HbX, which is separated, and it overlaps on it. So they gives again HbA1c as a erratic values and abnormal positioning on the different positions. And again, the high HbF gives abnormal HbA1c in the different chromatographic presentations. So what are the things which affect the HbA1c? First is assays, that is hemoglobin derivatives, low hemoglobin F, chronic renal failure, and the hemoglobin variants that can affect all three, that glycation rate, lifespan, as well as the assay interference. But again, the glycation rate is affected by vitamin C and E supplementation when it is improves, and they decrease the actually glycation rate. So falsely low HbA1c is detected. And iron deficiency anemia, again, some studies says not affected. Some studies did show that there is apparently high levels of the rapid turnover because of the low lifespan. And the factors which affects the lifespan of the RBC, which can again affect the HbA1c, is that vitamin B12 deficiency, splenectomy, hemolytic anemia, chronic liver disease, splenomegaly, rheumatoid arthritis, and certain drugs as well. So when you interpret the HbA1c, look at all the factors, look for the patient. When you see the patient clinically, this should not be there, and the patient history should be taken carefully to avoid the misinterpretation of HbA1c as well. So interpretation errors are method specific. As I said, the chromatographic methods, the iron exchange methods, all these things are different. HPLC, so biochemical inconsistent glycation and changes in the lifestyle, all these cause interference of the HbA1c. As I discussed in brief, that is deficiency anemias cause HbA1c rise, hypothyroidism, again, there is a good study from our IPGMR did it, Dr. Rana Bhattacharya and others, the team did it, and decreased HbA1c, again, the patient is on CKD, on erythropoietin, again, that HbA1c apparently may be low, again, the CLD as well. This is their presentation of, this did show that hyperthyroid and hypothyroid has altered HbA1c at the presentation compared to the control patients. Similarly, this pre-treatment and post-treatment of the patients also improves the HbA1c level without changing the glycation pattern as such. So these things again should be kept in mind. Patient with the hypothyroidism, patient should be controlled to interpret the HbA1c levels. RBC destruction, as we have discussed, that splenectomies, certain drugs like dapsone, ribavirin, ARTs, all these can affect the hemoglobin variants, and hemoglobinopathies definitely cause decreased HbA1c levels. These are the factors which affects the glycation itself, like alcoholism, CKD, all these can increase the HbA1c, aspirin, vitamin C, vitamin E, as I've discussed. There are some genetic influences of the genetic mutation of the N-terminus glycine of the gamma globin chains, thus leading to 15% acetylation and alters the HbA1c. So there are, I'm not going in details, again, hyperbilirubinemia, carbon-mediated hemoglobin, hypertriglyceridemia, and different hemoglobinopathies we have discussed have an effect. This is a very busy slide, but what I mean to say is that all the methods has their advantages as well as challenges. For example, HPLC, they have advantage to detect the most of the hemoglobin variants, but they are susceptible to interference from variants as well as hemoglobin derivatives and hemoglobin F. So this is maybe end up with a case maybe in real life. The 48-year-old lady, type 2 diabetic for 12 years, on insulin and metformin, HbA1c is 10 when you detect it, as a hysterectomy for fibroid. Average glucose for the measurements is 191 from the CGM, but which is corresponds to the 8.3. So we see there is a mismatch. And if you do the fructosamine, when we commonly do when there is a HbA1c is not as standardized, we feel, so that is again high. So why it can be? Because when you look at the other parameters of the blood, hemoglobin is low, and that again, as I've discussed, can affect your HbA1c. So this is how we interpret the whole of the patient's data along with the HbA1c to get a correct interpretation of HbA1c. So for take-home message, glycemic monitoring, HbA1c plays a very important part along with the CGMs and others, recent advances, but still the HbA1c holds very strong role in the management of diabetes. It's the most validated parameters. It can be done any part of the country, anywhere, even in the periphery it is available compared to the other recent advances. HPLC is the most validated method. Consider the potential interference when we interpret the data, but I've discussed, I tried to discuss, but there are many more left behind. History and background of the patient and the patient's drug history as well. Everything should be kept in mind when we interpret the HbA1c data. So I end up my talk here. Over to the question, if there is any.
Any question?
Thank you.
Thank you.
Thank you. Thank you very much.
Neil Gupta, beyond HB1AC Insights.
For inviting me here. Special thanks to Dr. B.C.Roy Patni. Now it's going to be a little overlap on this particular talk when it comes to beyond HbA1c, and when I was going through, I thought that I should talk more of a clinical viewpoints here and what is there in the kitty we have at this moment of time, rather than talking about the theoretical aspect of monitoring. So we will have this agenda as HbA1c. What are the limitations we have? I'll talk on TIR and the plasma blood glucose, HbA1c. What is the correlation, clinical implication of the present talk, and the carry-home message. I feel everyone knows this SMBG. When I started in practice in 1992 or 91, that time it was the glucometer which was available. HbA1c was not in the clinical practice. And then I purchased the first glucometer. I feel Dr. Rajiv Chawla must be aware of it, and even to some extent Sujoy, that I purchased a glucometer 24,000 rupees those days. And the strips used to be around 70 to 80 rupees. Now if I just convert those 25,000 rupees of 1992, it will be, I feel, more than how many lakhs, I don't know, but that is the cost of the glucometer. And then strips used to be around 70 or 80 rupees those days. But subsequently, technologies have made the things available for every one of us. And then HbA1c has come, and HbA1c has become a gold standard. But in the previous talk, we have understood that it is one of the blood glucose monitoring device which was approved by ADA in 2010, but it is existing since almost now more than 3 decades. But then we realized HbA1c is not enough, SMBG is not enough, and then we have another aspects of glycemic control and monitoring which has to be addressed, which is glycemic variability, avoiding hypoglycemia, limiting glucose variability, improving glucose control, so that we can have a better outcome. Because there used to be some odd outcomes where we failed to really get correlated with HbA1c, and that's why glycemic variability have been then addressed and hypothesized that this could be the reason in causing more oxidative stress. And then the newer glycemic targets have come with the invent of CGM, and then now we say it is not the HbA1c alone, it is not fasting postprandial alone, but also you have to have continuous glucose monitoring. You have to now focus on TIR, time in range, and time above range and time below range to correlate and give the better future for the people with diabetes as a whole. So HbA1c is certainly is one of the still gold standard, correlates well with the average blood glucose, predicts future complications, is a good risk marker, whether it's DCCT or UKPDS or any advanced accord, any trial you say, and you have the HbA1c as a gold standard, and it has been correlated with all those outcomes. It is easy to measure, and it is understandable, easy to and medium to long-term targeting setting. But however, we have still limitation. We have limitation that in patient with iron deficiency anemia, which is very common in the country, it could be showing higher readings. Pregnancy, it could be showing lower readings. You have a lot of hemoglobinopathies across, and that could be giving you abnormal values depending on the hemoglobinopathies you have. So anemia, uremia, CKD patient will show you little higher reading, and it is being said that we should not be monitoring HbA1c once you are into end-stage renal disease. And then ethnicity-wise also, there is some disparity between the Caucasians versus Asians, and it fails to provide the data on the hypoglycemia and glucose variability when it comes to HbA1c. So where we should not be doing HbA1c is in patient with severe anemia, polycythemia, hemoglobin variants, hypersplenism, splenectomy, chronic kidney disease, stage 4, G6PD deficiency, acute blood loss, the blood transfusion, patient on dapsones or high dose of aspirin, some antiretroviral drugs, and if the triglyceride is too high. So these are some limitations, and that's why then the next metrics which has come is CGM, which covers your all aspects. I feel there was a talk on CGM, so I'll be very brief in this. There are some undetected hypoglycemia, undetected hyperglycemia, which all get missed with when you talk about SMBG, or even when you talk about HbA1c, and that need to be taken care by AGP. And this is a very basic graph which we are seeing almost since now 7-8 years, that you have HbA1c almost similar, 6.7, 6.7, 6.7, but you have the hypoglycemic episode here. It's 1%, 6%, 9% glucose variability, is 26, 42, and 53%. So, despite having same HbA1c, you have lower GV or higher GV, and higher TIR and lower TIR. So, when you talk about HbA1c, you might be missing out this risk of hypoglycemia and HbA1c in such patients. So, when we talk about CGM, it is A1c cannot capture the glycemic variability and glucose excursions. CGM, a small sensor is placed under the skin to measure interstitial glucose, and it measures is either 5 minutes or 15 minutes. The AGP which we are using now is 15 minutes. Many of the CGMs which are with the pump, they are every 5 minutes, which runs for 7 days. It provides a comprehensive assessment and can inform patient with impending glucose excursions, and will have alert arrows there with it. This device continues to become easier and will be possibly more cost effective if suppose someone comes out this particular device coming from some Indian subcontinent, and if you have some research product coming from here, and so this is there are various metrics. Out of them, what is most important is TIR, time in range, time below range, time above range, and there are 2 levels of above and below range. That if you have I'll use the pencil here, yeah. So if you have it is level 2 more than 1, 250, level 1 is 180 to 250, and time in range is 70 to 80. Similarly, hypoglycemia has been again divided into 2 levels, that you have level 1, which is 54 to 69, and less than 54 is level 2 hypoglycemia. So it's 70 to 180 TIR is the duration of patient's blood glucose within individual's target. Also important to interpret the time below range and time above range. And it's one of the meaningful tool for all of us to put it into clinical practice. This is a diagram which is showing this is 0 times time in range. There's no reading which is in range. There's 25% time in range. There's 50% TIR. This was 70% TIR, and this is 100% time in range between 70 to 180. So, and the data says that TIR and HbA1c relationship, if every 10% increase in TIR can reduce HbA1c by around 0.8%. And if you achieve 70% of TIR, then it strongly correlate with the HbA1c goal of 7. That's why the recommendation is that we should try to achieve 70% of TIR in all the patients, except in pregnancy, in GDM and pre-gestational type 2 diabetes. So I'm not going to too much detail of it because this topic is already being covered by Amit in the previous session. So you have another new change here. Now earlier they used to give it HbA1c as a reading, but this 7.6 now they call it as glucose management indicator, GMI. Because people are getting confused because this exactly does not correlate with the HbA1c you do. So you get the time in range, you get time below range and time above range. Now decreasing TIR is associated with increased long-term complications independent of the HbA1c. This is data from the DCCT trial. This is the extrapolated data which has shown that each 10% reduction in TIR increases the retinopathy risk by around 64% and the risk of deterioration of microalbumin by around 40%. There's another data in type 2 diabetes, 3,000 plus patient prevalence of diabetic retinopathy by severity increases with decreasing TIR. So this is the, if you have the TIR of more than 86%, you have whether it's mild NPDR, moderate NPDR, or the vision-threatening diabetic retinopathy. If you have TIR which is in the range of more than 80%, you have reduced risk versus as the TIR reduces, the risk of retinopathy increases. And this again, I told you the same data from the DCCT trial, and there is strong association of risk of development of progression to retinopathy if you have the time in range less than 10% versus more than 70%. And this is one of the very promising data showing that if your TIR is more than 70%, then certainly you have less risk of having retinopathy. Similarly, development of microalbuminuria again has been correlated with the TIR. So higher is the TIR, less is the risk of deterioration in retinopathy, in the nephropathy. And this is again a data from the diabetic retinopathy, where it was graded as non-DR, mild NPDR, moderate NPDR, and vision threatening. Almost the same data which I have shown you in the earlier slide. And in the quartile where you have higher TIR, have lower risk of having every type of retinopathy. And this is about the cardiovascular mortality. This is around 6,000 type 2 patients, where decreasing TIR was associated with increasing risk of all-cause cardiovascular-related mortality in the cohorts here, whether it's all-cause mortality or whether it's cardiovascular mortality. It was showing higher if you have reduced TIR. And same correlation has been again shown. This is the same data, but the prevalence of peripheral neuropathy. And this neuropathy, again, they have shown that symptomatic neuropathy was more if you have low TIR. So what are the indication of this CGM is all type 1 diabetes, type 2 treated with intensive insulin therapy, not meeting the glycemic control, or those are brittle diabetes. ACE says type 1 diabetes with hypoglycemia and unawareness, type 2 diabetes on intensive insulin therapy, and ADA says type 1 not meeting the glycemic goals, hypoglycemia unawareness, sensory augmented pump therapy, or those it may be considered in pregnancy. And these are the recommendations. Again, this recommendation have already been discussed. I will not go too much into detail of it. Overall, we say type 1 and type 2 diabetes 70%. But those who are very much on higher risk of having cardiovascular disease, elderly patient, in this patient TIR can be up to 50%. But of course, the TBR should be less than 1% here. Pregnancy area of my concern, where I'm too much interested in type 2 diabetes, type 1 diabetes pregnancy up to 70%, more than 70%, and pregnancy with gestation and type 2 diabetes, we should try to achieve 80% TIR, and in GDM and pre-gestational type 2 diabetes. So overall, there's evidences which are demonstrated in patients with type 1 diabetes, those with type 2 diabetes. It reduces HbA1c, reduces hypoglycemia, increases TIR, reduces hospitalization, better quality of life and satisfaction, and less absenteeism. In pregnancy, there's a data from concept study, and they have shown that these evidences from both the study and type, there's 5% reduction in TIR, have 5% increase in TIR in the second and the third trimester, may be related to macrosomia. So currently we have many of these available across from Abbott. We have available, Medtronic available. Eversense is not available in India. Dexcom has come, but I'm not sure very much in central India it is not available. There are going to be a few further sensors like Eversense, which is going to be a implantable device which will be acting for around 6 months, and which might also be of use in future. There's another CMM sensor, which is continuous multi-metabolic monitor sensor, and this again is implantable one, and this might work for almost for up to 2 years. And this is a K-watch, which is using where it's a device which can be used as a watch here, and it has a digital display here, filter, and this actually works on the principle of radio frequency sensing, and there are some trials going on. There's skin patch which will be also monitoring your blood pressure, heart rate, and glucose and lactate, even alcohol levels and caffeine. These all are under trial. And the carry-home message, before I go, I was discussing with Dr. Rajiv Chawla. He said, why are you not talking about 1,5-G, AG, and fructosamine? I said, this is not into the clinical practice, so I have just skipped those slides. But certainly in future, because of the limitation of HbA1c, fructosamine, when in our early days of practice, sir, we have used this in pregnancy, but it has an average blood glucose of around 2 weeks. But I feel it was not acceptable those days, and now no one uses it. A5G, yes, A5AG must be can be used, but I feel we still have to have good data from this part of the world, and there are only very few papers on this. So carry-home message is the use of TIR enabled the diabeto endos and educators to analyze more than one component of the glycemic control. One of the possibilities of the future is combination of various metrics trying to have better glycemic control. Gathering more than one metric is an attractive idea when when analyzing diabetes control might be used more frequently over next years. And a recent consensus has said that we should have TIR of more than 70%. TBR at the level 1 should be less than 4%. TBR less than 54, level 2 should be less than 1%. Most of the individual with type 1 or type 2, although target should be individualized. Different targets should be considered for elderly people and high-risk individuals who are at high risk of having hypoglycemia, and pediatric population and pregnant. However, beyond HbA1c, when you talk about practicability in our clinical practice, a lot more to come with the promising future. With this, I stop here. Thank you very much, DRWA, once again. Wish you all a happy Wali life always. Stay safe, stay healthy, and keep smiling. Always use fruits to cut. Today is a Father's Day, and wish you all, most of you are fathers here. So wish you all a happy Father's Day. But don't cut the cake. Don't ask your children to give you cakes and cookies and put you again loads of hydrogenated fat. Instead, cut the fruit, cut the watermelon, cut the muskmelon, cut the oranges if you don't have anything, or cut the apple for celebrating any occasion like Father's Day. Thank you very much for patience listening.
Thank you very much, sir, for wonderful deliberation. If you have any question, 1 or 2 questions will be
I have procured a few of the slides from Rakesh, few of them have come from Alok, possibly, I don't know, from recently held Hello Diabetes Academia. The 2 last few slides I have taken from you. He conducted a wonderful workshop in Hello Diabetes Academia on technology of 1.5 hour workshop, and was one of the very popular and very well taken workshop there in Nagpur. So that's a disclaimer. Thank you very much.
There is one pen drive which is lost of Dr. Manoj Chawla, sir. If anyone finds, which color was that? Okay, it was Diabetes India keychain.
So next, I have the honor to welcome Professor Sujoy Ghosh, Professor at the Department of Endocrinology, Institute of Postgraduate Medical Education and Research, Kolkata. Sujoy doesn't need any introduction because he is well known throughout the country and even abroad, and he's a prolific researcher and academician with a huge amount of publications, and the USP is his straight talks and unbiased opinions. So I welcome Dr. Sujoy Ghosh, who will be talking about myths and facts about the use of SGLT2 in atherosclerotic cardiovascular disease. Over to Sujoy.
Thank you, Sanjay. Big thank you to the organizers, particularly Vijayda, for having given me this wonderful opportunity to speak. And every conference that you go to has, 10, 15 talks on SGLT2 inhibitors. So whatever I speak today is probably not going to be liked by pharma, but is actually the reality. So how did the story start? It was almost like a fairy tale. Those of you who attended the EASD meeting at Stockholm would have heard the presentation of the EMPA-REG trial, and thereafter, particularly BI, along with its partner, has almost brainwashed into understanding what the EMPA-REG trial is all about. So, as you can see here, there was a 38% reduction in cardiovascular death, 32% reduction in mortality, hospitalization rate went down, and the 3-point MACE went down. But, if you can see, the curves in the EMPA-REG trial spread out very quickly. So, do you expect atherosclerosis to change that quickly? And that entire 3-point MACE was driven by CV death. Nothing happened to non-fatal MI and non-fatal stroke. And the greatest benefits are all non-atherosclerotic deaths and not atherosclerotic cardiovascular deaths. The US FDA jumped in and approved the drug, saying that if you want to reduce cardiovascular death in type 2 diabetes, atherosclerotic, start using SGLT2 inhibitors. And there was an editorial that came out, a commentary, when the DAPA the DRWA trial was published, because you remember the DRWA could not show the benefit of the 3P MACE. And this is Subodh Verma's article, which talked about the drug that works on the pumps, that is the heart failure, the pipes, that is atherosclerosis, and the filter, that is the kidneys. And then they said, as far as the pump and the filter is considered, it works all through, whether it's primary prevention or secondary prevention. But when it came to pumps, the pipes, it did not work in all. And this is the guideline, the holy grail of management of type 2 diabetes. And if you talk about ASCVD predominates, this is what the guideline tells you. You use either a GLP-1 receptor agonist or you use an SGLT2 inhibitor. So this is what we have been taught. Now this was a wonderful editorial which very few of you might have read, which actually bears naked the truth about SGLT2 inhibitors. So I already told you within 3 months the events rate was different. Atherosclerosis does not change that quickly. You could not prevent non-fatal events, yet you prevented deaths, which is against the basic understanding of pathophysiology of any disease. And if you look at the EMPEREC trial, 40% of the deaths prevented were presumed cardiovascular deaths. It was not proven. And 99% of the patients in the EMPEREC were patients who already had established cardiovascular disease. That's not what you see in your clinical practice. Now, this is a beautiful paper by Inzaki in Diabetes Care, who tried to figure out why did people benefit in the EMPEREC trial. And they found that the only predictor of benefit was change in hematocrit. Now, is atherosclerosis related to your hematocrit? Unlikely. The heart failure is related to change in hematocrit. So we went on to do 2 meta-analyses to try and look at what do these drugs really do. First of all, do they prevent deaths? This we published in Endocrine Practice. And whenever you're talking about a drug, say for example statin, the first thing you want is that the numbers will normalize. Then you will look at that the targets have been achieved. And you look at surrogates. Carotid intimal thickness has improved. Atheroma volume has improved. Then you look at non-fatal events have gone down. Then you look at fatal events have gone down. And then you look at all-cause mortality. That's your hierarchy of benefit of any drug. Now, we do understand that there are problems with meta-analyses because there's going to be a huge amount of heterogeneity. In spite of that, the best that you can get is a meta-analysis of all the well-designed RCTs. And because unlike a lot of other drugs, you have so many RCTs and you're looking at a population of more than 50,000 people. For any other drug, do you have so much of evidence? And the drugs have been tested for various indications. Maybe one is a renal outcome trial, one is a heart failure trial, one is a cardiovascular outcome trial. So you've got a mix of people so that you actually get an understanding of what's happening in terms of events and deaths. So I'm going to skip the methodology. This is the baseline. And if you look at the cardiovascular mortality overall, with SGLT2 inhibitors, you are definitely preventing deaths. There is no controversy about that. So CV death is prevented by all SGLT2 inhibitors combined. Now this question about empagliflozin being the best SGLT2 inhibitor, which is ingrained into the minds of doctors, does not actually stay true. All of the SGLT2 inhibitors are same if you look at this meta-analysis in terms of cardiovascular mortality. And it reduces cardiovascular mortality by about 15%. Now what about all-cause mortality? Again, you can see consistently across the board, all-cause mortality is reduced by SGLT2 inhibitors, and it's probably the same for all of the drugs. In fact, in this, if you're looking at subgroup analysis, DAPA and CANA probably did even better than EMPA. So 14% reduction of mortality. So what kind of deaths are we actually preventing? Deaths are being prevented, there is no doubt. And death is a very hard end point. You just can't fudge death data. So the next meta-analysis which we published was in the Journal of Clinical Endocrinology and Metabolism. So we wanted to show that are these deaths related to atherosclerotic cardiovascular events, or are these heart failure related deaths? So we went back to all of the cardiovascular outcome trials, and we went to the supplementary data of all of these cardiovascular outcome trials. There you will find there is a separate section which tells you so many fatal MI, so many non-fatal MI, so many fatal strokes, so many non-fatal strokes, and so many undefined deaths. So if you look at the defined myocardial infarction, whether fatal or non-fatal, and you look at the defined stroke, fatal or non-fatal, you will get an idea of what happens to myocardial infarction and what happens to stroke in patients when they are prescribed SGLT2 inhibitors. So if you look at myocardial infarction overall, whether it's fatal or non-fatal, there is no change between the placebo group and the active group. So myocardial infarction is not reduced by SGLT2 inhibitors. What about strokes? Whether it's fatal or non-fatal, the diamond of the meta-analysis is exactly in the midline. It does nothing. There is no change. Now you might then argue and say, okay, I'm going to look at only the non-fatal events, because non-fatal events should be easier to prevent. If you look at that, there is no difference in non-fatal MI plus non-fatal stroke. And if you're looking at all atherosclerotic cardiovascular events, whether it's fatal or non-fatal, whether it's MI or whether it's stroke, there is no difference. So essentially, you can see from the meta-analysis that when it comes to atherosclerotic cardiovascular events, there is no change. Now this commentary was published by JCM on the basis of our article, and this is what it reads, and I'll read it out. Most recently, SGLT2 inhibitors have demonstrated to reduce the risk of cardiovascular mortality, progression of heart failure, and reduce the risk of heart failure exacerbation. Therefore, it seems like a plausible explanation that the primary driver of SGLT2 reducing MACE may be because of optimization of heart failure and volume status. I showed you Inzaki's paper of alteration of hematocrit. The explanation is intuitive that SGLT2 inhibitors reduce renal glomerular reabsorption, which then lead to volume reduction via osmotic diuresis and natriuresis. The highlighted findings by our study represent an opportunity for FDA to reconsider the stratification of cardiovascular mortality analyses in clinical trials as suggested by the authors. In the future, mandates considering separating cardiovascular mortality events associated with ischemic or atherosclerotic events from those related to heart failure. So we've learned now that when you're talking about cardiovascular outcomes, you should think of the outcomes in terms of heart failure outcomes and the atherosclerotic cardiovascular events outcome. Now this I will back up with two relatively recent publications. The first is the DRWA study. This was done in individuals with myocardial infarction without diabetes or heart failure. So this is a very specific group. You will understand whether atherosclerosis is being modified, because we say someone who's had a heart failure is at very high risk of having another heart attack, right? So here you can see this is an international registry-based study, randomized, double-blind of 10 milligram of DAPA, and people tried to look out for the outcomes. And what was the outcome? In patients with acute myocardial infarction, approximately 1 year after treatment of dapagliflozin, there were significant benefits with regards to improvement in cardiometabolic outcomes, but no impact on the composite of cardiovascular death. So you're talking about a drug, post-MI, no impact on cardiovascular death or cardiovascular events. Now this is April 2024. Empagliflozin after acute myocardial infarction, published in NEJM. Again, this is a double-blind, randomized, placebo-controlled trial, 1:1 ratio, for patients who had been hospitalized after an acute myocardial infarction and were at risk of heart failure to receive empagliflozin at a dose of 10 milligram. And the primary endpoint was composite of hospitalization for heart failure or death. Now, what did you find? Among patients treated for risk of heart failure after MI with empagliflozin did not lead to significant lower risk of first hospitalization for heart failure or death. Now, I believe that editorial which was published by Subodh Verma, we need to take out that pipe out of that editorial. So you talk about pumps, fine. You talk about filters, fine. Forget about the pipes with SGLT2 inhibitors. And this particular guideline, where in atherosclerotic cardiovascular events predominates, we talk about A or B, that needs to be A and B, because if you really want to prevent atherosclerotic events, either choose a pioglitazone or choose a GLP-1. It's a pretty tricky pathway of how you actually analyze clinical data and how pharma presents that to us. Use your brains and understand that if you really want to prevent atherosclerotic events, give something like a pioglitazone and a GLP-1. Those same individuals will be at a greater risk of heart failure. Therefore, use an SGLT2 inhibitor, but with this in mind that that drug will not prevent atherosclerotic cardiovascular events. Thank you very much for your patient hearing.
Excellent presentation. So, are there any questions from the audience? No.
Thank you.
Thank you very much.
Our next session is on diabetes, advances and research 2. For this session, I would like to call upon stage Dr. R.S. Agarwal, Dr. Shondeep Mondal, Dr. S.S. Poddar and Dr. Srihari Kulkarni on stage. We welcome you all.
Dr. Partha Biswas, can you come on the chair, please? Dr. Rajesh Kesari, please come on the chair. Dr. Agnik, can you come on the chair, please? Agnik Pal, please start the session, please. Partho, can you start the session?
Good afternoon, all. Now you are moving into the session Diabetes, Advances and Research. Our next speaker is Dr. Rajiv Chawla. He will speak on navigating challenges in diabetes. Dr. Rajiv Chawla is a senior consultant diabetologist and is a very well-known and prolific speaker. Sir, the podium is yours.
Thank
Dr.
you.
Rajiv Chawla.
Thank you for the kind words. Thanks, Dr. Patni, for this opportunity. And task assigned to me is to navigate the challenges in diabetes care, even towards the end of 2024. So what I'll do is I'll try to navigate these challenges under various headings: higher prevalence and unawareness of diabetes care in India, issues related with diagnosis and access to the treatment, the financial constraints, the social barriers, the economical disparities, adherence to recommended guidelines and management challenges, and towards the end I'll touch upon the complication, how they pose huge challenge to a clinician in terms of management. So when we talk about diabetic burden of India, the current figures, ICM of 2021 suggested that the prevalence of diabetes in India today is close to 11.4%. But what is even more alarming is that you have almost 15.3% of people having pre-diabetes. So it is something like a situation you are sitting on a time bomb with almost 101 million known diabetics and 136 million pre-diabetes patients who are likely to get converted to type 2 diabetes over next 5 to 10 years. Even if you talk about a lower conversion as low as 20 to 25%, so you may imagine the huge amount of burden which is going to come over next 10 years. And unfortunately, diabetes has no boundaries, irrespective whether you are rich or poor. No more it is a rich man disease or a disease only to metros. Even the rural population except the Uttar Pradesh, which had the lowest prevalence, less than 5%, most of the states today have a prevalence close to 10%. So there is a huge burden of uncontrolled diabetes in India today. CARS trial 2020 said that only 4 in 5 people with diabetes have HbA1c less than, only 1 in 5 have HbA1c less than 7%, and almost 70% or 80% patients, they still have an HbA1c more than 7. When we are talking of, there was a debate by Anuba that we must target 6.5, early days less than 6.5, and I think I must congratulate her. She won the debate that ideally it has to be less than 6.5. So when we are talking on cards, we are talking about HbA1c less than 6.5, and when we see the reality, whether it is IDCA 2020 study, we have only 22% making it to HbA1c less than 7%. So it could be the fact that there is a still lot of unawareness about diabetes care in India. There is a lack of knowledge about diabetes which can hinder overall management of diabetes, and this is what was highlighted in Cures, which said that nearly 25% of the population was unaware of diabetes, and only 22% of the population, those who were known diabetic, or those who were known diabetic, only 40%, they felt that diabetes could be prevented. So we are still living in ignorance. So this lack of awareness obviously puts all these patients to a greater risk for developing micro and macrovascular complications, and in certain population group, diabetes is regarded as a curse for past sins, unfortunately, even today. So they may not go to a physician or an allopathic physician for getting the right treatment. Even diagnosis, and once you get diagnosed, even then you might not have a good access to the treatment. There is going to be a delay in diagnosis of diabetes, which further worsens the risk of micro and macrovascular complication and increases morbidity and mortality. And this is what Diabetes Care Asia, which was a multi-country study in Asia, highlighted that Indian subjects are determined at a very late stage. So it's not surprising when UKPDS said that close to 40 to 50% patient, by the time they have diagnosis of type 2 diabetes, they already have one or other complication. And almost, I think, 20 years ago, 2005 or 6, I presented my own data in RSSDI, talking about 40% patient right at the time of diagnosis having one or the other micro or macroangiopathy. Retinopathy background we saw in almost 16% right at the time of diagnosis, and neuropathy was again seen in about 19% of the patient. So moment you come to know your diagnosis, still there are financial constraints. Not everyone might have an access to a good treatment. Most of them may not be able to afford it. So this is again because of the fact that there are no sustained or fixed reimbursement plans or policies. Unfortunately, in India, till now we don't have an outdoor coverage at all. It is now for the first time there is one plan which is getting launched, which is going to cover for the first time even the OPD expenditure also. And most of the government institutions again may not have best, forget about Dr. Sujai's institution, which is one of the best centers in the country. Otherwise, most of the government setup may not have the best standard of care, and those private institutions or tertiary care may not be very well affordable to most of the patients. So this financial constraint, again, one of the study which got published in 2013 by Vijay Vishwanathan talked about that there could be very high costs for hospitalization. Even doctor visits accounts for 12% of the cost. Monitoring and frequent lab tests maybe annually, and of course the anti-diabetic drug. And mind it, this was when sulfonylurea was a standard care. When we are talking about SGLT2, GLP-1 receptor agonist, oral or injectable, I am sure the cost of anti-diabetic therapy today may be more than 70% or 80% contributing towards overall financial burden to the patient. Then there are social barriers. Social cultural barriers could be again blocking the proper management of type 2 diabetes, because it is still taken as a stigma, especially type 1 when it comes to younger children, more so female children. It becomes a stigma, and many a time they will not disclose, and they might miss an insulin dose rather than disclosing it to their classmates or their schoolmates. And there are then economical disparities in healthcare system and health education because of lack of adequate facilities in government or other institutions which are being run